Dr. Ingrid Waldron is Professor and Hope Chair in Peace and Health in the Global Peace and Social Justice Program at McMaster University. Waldron's the founder and director of the ENRICH Project and the co-founder and co-director of the Canadian Coalition for Environmental and Climate Justice. She partners with equity-demanding groups because their health depends on this thing called structural competency. There's a massive body of research on the impacts of racism and other forms of discrimination on the health of communities, and plenty of political and legal force behind recognizing the ongoing lethal effects of environmental racism, but still it seems like an uphill battle. So back in 2020, Waldron collaborated with Elliot Page to turn her book There's Something in the Water, a study of environmental racism in Nova Scotia, into a feature-length documentary. Her new book, though, From the Enlightenment to Black Lives Matter, tracing the impacts of racial trauma in Black communities from the colonial era to the present, is what we mostly focus on here. The book traces the history of Black racial trauma in Canada, Britain, and the US, but it's also kind of a manifesto, demanding a politics of structural transformation in medicine, and maybe especially psychiatry, as a way of moving past their rigidity and advocating for changes at the root structural level. Waldron is saying that because racism places obvious restrictions on the ability of human beings to thrive in their social worlds, it also places an insurmountable burden on the equal distribution of health. I think there are moments in this discussion where it feels like Dr. Waldron might even be satisfied with the medical community if it could just recognize and respond to racism as a factor that has a huge impact on a person's health. Demanding an anti-racist politics in academia and medical practice, she says, we need to make it standard practice to care about radical structural change, and especially where the politics of race and things like psychiatry collide, because the lives of people from already disadvantaged, equity-demanding groups are at stake.
Welcome back to the podcast. It's exciting to see the release of your latest book, which is entitled From the Enlightenment to Black Lives Matter, Tracing the Impacts of Racial Trauma in Black Communities from the Colonial Era to the Present. The book is really a tour de force. It covers an enormous amount of ground, so I hope we can sort of do it justice today. To quote the book, you say that since the Enlightenment, Black bodies have been sites of trauma, and the Black body has held a complicated place in the white imagination. So I kind of wanted to start, even though we're starting very big picture here, by talking about Blackness as a racialized state of being that in health and historical terms, we could describe, you say, as having indigenous knowledges, in the sense that there are these ideas of health, of healing, of psychology that are, you talk about how it's rooted in a system of belief that Western medicine has not been really willing to try to understand, I guess I'll say. So, I was hoping I could start by asking you to help your readers understand what the white imagination is, and maybe in terms of how it gets realized through these powerful structural forces like science, medicine, and so on.
I mean, the white imagination to me is essentially socially constructed. It's the ways of knowing and ways of being that inform how white people see the world, which once again is socially constructed. So white people have understandings that come from, of course, their own perspectives and their own traditions, and ideas about how the world should be and how people should operate within that world that is informed by your Western ideologies. So individuals, racialized people, for example, and Black people often complicate that worldview, right? And I think white people then want to try to make sense of that, but in making sense of that, many of the actions that they take are harmful to Black people and people who are outside of that imagination of how they see the world. And that means the knowledges and experiences of people who are not white are often sublimated in favor of what is seen as normative white understandings of the world and ideologies. So when I say that Black people hold kind of complicated space in the white imagination, is that I think often white people don't know what to do with Black people. Our understandings of the world, our traditions, our philosophies are not understood, are therefore undermined, and then are often seen as inferior because they're different, because they're not understood. And that informs what's happening in every single social structure. In this book, I happen to take up the issue of mental health and psychiatry and other mental health professions. And what I'm saying is, since the Enlightenment, but even before then, there have been these stereotypes and perceptions of Blackness, of Black people. And there has been, I think, a project in many ways to harm Black people uh, within many of our social structures because Black people are not understood, because we are seen as complicated beings that white people find difficult to understand. Our foreignness is often seen as, once again, inferior. And our understandings of the world, our ideologies, our philosophies, obviously many of them rooted in African philosophies, African indigenous ways of knowing, there's a project to undermine and sublimate those ideologies. People are fearful of African philosophies, ideologies. They're seen as exotic. They're seen as not evidence-based. They're seen as not rooted in anything real or tangible or scientific for many white people. So they're often on the outskirts. They're on the periphery. So what I'm trying to do in the book is to center African indigenous knowledges and African ways of knowing. But in the case of this book, I'm focused on psychiatry because I think it's been really harmful. I think psychiatry has been harmful to Black people. All the stereotypes that we hold, the negative stereotypes we hold about Black people have found their way into psychiatry and have then informed how psychiatrists and other mental health professionals assess, diagnose, and treat Black people.
Yeah, I mean it's a really big component of the book, especially this like engagement with stereotypes, which you convincingly show are genuinely pathologizing things that have material impacts. It's not just something intangible. I think there's little room for any sort of doubt after you've read the book about whether stereotypes of the Black body as superhuman, for example, as invulnerable, do play a role in deciding the health outcomes of entire Black communities. And I wanted to ask you about that because there is an assault on sort of trauma-informed medicine, on racial justice in terms of environmental protection and the fight against environmental racism in the United States, but not exclusively in the United States. And given that so many of these stereotypes still have a controlling effect, I wanted you to build on basically what you argue in the book, which is that not only does health tend to forget the effects of trauma, it also can't see how racial and racist stereotypes in health institutions and policing and in policy all perpetuate trauma.
Yeah, I mean, trauma-informed care is now a very popular concept and action, and a lot of people in healthcare are talking about it. And what I argue in the book is that it is a great first step in understanding the racism, the racist experiences that Black people have to contend with throughout their lives. It's a really great step because it sees the experiences of people as experiences that lead to trauma. What I think it omits is the very specific experience of racialized trauma, and that's because our healthcare system still does not acknowledge racism as a health issue. It does not acknowledge racism as a valid and legitimate structural determinant of health, despite the fact that a major Canadian health association back in 2018 wrote a position paper finally affirming racism as a health issue, as a structural determinant of health.
Mm-hmm.
Now, I certainly didn't need them to tell me that because I've been doing that work for a long time, but it was really the first time that a major health association made that claim. Despite that, and that was once again back in 2018, our universities, medical faculties, the health professions have still not acknowledged racism as a serious and legitimate health issue. They're not, for the most part, teaching racism as a health issue in courses, right? So that's the root of it. If we can teach this information to students, then they're going to come out with a different perspective, and that's going to be incorporated into clinical practice. It's not incorporated into clinical practice because our universities are not teaching this. So once again, you know, trauma-informed care, fantastic first step. But if we're not talking about the experiences, very specific experiences of Black and other racialized people who often have to contend with racialized trauma and intergenerational trauma and how that has real impacts on health and well-being, then trauma-informed care, for me, does not go far enough. I see it as a good first step because it allows a clinician to start that conversation with the racialized person sitting in front of them to explore their experiences in full. You know, clinicians often talk about client-centered care, patient-centered care. It's a term that they love in the health professions, patient-centered care. And for many of them, they use that term to talk about the need, once again, you know, obviously to center the patient's experiences, but they often don't incorporate the experiences of racialized peoples that often come with racism. There's a cautiousness about entering into that conversation or a lack of knowing, right? So in order for clinicians to address many of the issues that racialized people face, it requires a much more fulsome discussion than they're having. And racialized people will often say that I didn't want to go back to that therapist because they didn't understand me, or I didn't want to go back because of the experiences that I had that were racist, or because that person didn't look like me, they didn't share my cultural experiences, they didn't, you know, often racialized people will say, they leave it at that, they don't share my cultural experiences, but that would also extend to my racial experiences. They want to know that the person sitting in front of them understands them, and understanding them means that you will eventually engage in a discussion on sometimes racism. And that doesn't mean that every single racialized person feels that they've experienced racism, because I know many racialized people, Black people, who will say to me, Ingrid, I've never experienced racism. So it doesn't always have to be a conversation, but the clinician has to be prepared and comfortable and not nervous to talk about that. And many white clinicians are. And then you have white clinicians who don't believe racism exists. So it's very difficult for them to address the issues, problems, struggles of racialized peoples if they don't think it exists. So for me, yeah, so I don't necessarily have a problem with trauma-informed care, because I really do believe that just the word trauma, and I'm talking about racialized trauma in this book, I think trauma is an important conversation to have. But I also think that we have to be open to talking about racialized trauma in its many forms. How it plays out in all of our social structures, and be able to engage comfortably in a discussion with a racialized person sitting in front of you and really hearing it, because it plays, for many racialized people, not all, it plays a significant part of their lives. It plays a big role in how they see the world and how they experience the world.
Yeah, I mean, the data on what you're arguing really backs up the argument you make. I mean, the fact that we can actually detect at the genetic level in people's DNA the effects of historical and collective trauma. You say that this shows, quote, racism is not simply an idea, but also visceral in the way it's stored as sensation, tension, and pain. I've spoken with the biomedical researcher Kelu Fox about this.
Uh-huh.
His research is on indigenous people's DNA, and he really emphasizes this idea that colonial oppression is evident in the genomes of indigenous Hawaiians.
Yes.
So I kind of wanted to spend a little time on this because, it gets your gears turning. Like, what can that biomedical realization do in terms of mainstreaming the idea that anti-oppression, anti-colonial theory should be a part of scientific training?
Yeah. But I have two comments on what he said. So if you also look, there's a really great book by Resma Manakin called My Grandmother's Hands, where he talks about intergenerational trauma for racialized people, but I'm not sure if he's specific to Black people. And similar to this individual that you just talked about, he talks about how racial trauma is stored at a cellular level,
Right.
right?
Yeah.
Similar to this individual that you're talking about. So he's pointing to and arguing the real biological genetic interplay
Mhm.
between experiences of racism and the impact, the real impacts on the body, when he says that it's stored at a visceral and cellular level. And this reminds me of the field of epigenetics,
Mhm.
that I find very interesting, that I first learned about, I think, from a American cell biologist, Bruce Lipton. And I
Mhm.
thought what he was talking about was so fascinating. The role that negative experiences play on our biology. His first book, I think, on epigenetics is called The Biology of Belief. And
Mhm.
it also talks about your belief systems and how negative, that whole field of negative beliefs and negative thinking has an actual real impact at the cellular level on your body. So how do I extend that to racism and Black communities? Well, I would say that the experiences of racism, which of course is negative, rarely are captured by our biology on a cellular level, and therefore has impacts, real impacts on our health and well-being. So I agree with you when you
Yeah.
say that when we talk about issues like anti-colonialism and the different ways in which we should disrupt our colonial systems within all of our social structures and the need to address racism uh, is urgent
Mhm.
if we agree, and not everybody would, that this has real health impacts. But you still have people who find that hard to understand, right?
Right.
Because if they're starting at a place where they don't think racism even exists, then it's hard for them to kind of entertain this. But we now have, once again, evidence-based research. We've got scholars who are talking about racism at that visceral, cellular, biological level. And
Mhm.
then we have this field which is growing of epigenetics, which which entertains that. I mean, epigenetics is not necessarily about racism. It's
Mhm.
about negative external experiences. And indigenous communities are gravitating towards the field of epigenetics. I had a colleague when I was at Dalhousie by the name, she's indigenous, um, by the name of Dr. Bombay,
Mhm.
who's now at Carleton. And Dr. Bombay's main field of research was psychology, psychiatry, indigenous peoples, suicide, mental illness, residential schools, and the impact on mental health in indigenous communities. And I believe a few years ago, she started doing work on epigenetics, and it
Mhm.
actually engaged, it very much engaged indigenous people, the indigenous people she was reaching out to, right? So I think this is ongoing work with her. And she was talking about, which I found fascinating, that if you are a child, an indigenous child of a parent or grandparent who experienced residential school, so you as a child never did, but your parent or your grandparent did experience directly residential schools, you as a child can experience mental health problems because of that, which
Mm-hmm.
speaks to epigenetics, that there's some
Yeah.
kind of intergenerational handing down of that experience to where that child who has never experienced it could experience mental health problems. And I found
Yeah.
that to be fascinating.
Same. Yeah, no, it boggles the mind and should give us pause. But the thing that I find your book does, though, it's like a way of framing that information by centering just like questions of justice. And I think, where you land is in this language of health equity that I find really compelling. And that again frames it all very differently. Like there's no question that the data shows the persistent effects of colonization in health outcomes.
Yes.
Um, but and you're saying that like we see extreme levels of stress, high blood pressure, depression, cancer, and other realities proliferate in equity demanding groups. So I just, because you're talking about particular places like, your research here in Nova Scotia, your research in Hamilton, did you want to just sort of highlight some of the demographic statistics you uncovered for the book, how you derived some of your insights from the research studies you did in these specific places, and what you've discovered about, racial health disparities in Canada specifically?
Yes. I mean, this is work I've been doing for quite a while. This is the work that I did when I was doing my PhD. Um, Health disparities between more advantaged and less advantaged groups, specifically racialized communities and white communities, and particularly in Canada. I mean, that work was in its infancy when I was doing my PhD, but it's grown over the years among lots of people, but particularly Black scholars and racialized scholars. And we see that in Canada. We don't have the kind of data that they have in the United States. That's what many researchers lament in Canada, that we
Right.
don't have race-based data. We've been calling for that for years. We did kind of have it during COVID, particularly in Nova Scotia was one of the first provinces that was collecting race-based data with respect to COVID. They no longer are doing that to the same extent from what I heard. So what we don't have is what they have in the United States, which is race-based data where we can rarely talk statistically. So I can't even answer your question
Hmm.
because we don't have that data. What we have is qualitative research, which I've done, interviews and focus groups and other
Mhm.
conversations with racialized people who talk about the real, in many cases too, mental health impacts of experiencing various structural inequities within our various social structures. I'm currently doing research on dementia in Black communities. The study that I completed late last year, I believe, is the first ever study on dementia in Black Canadian communities, I've been told.
Hmm.
And the research is coming out now. We don't have that data yet in Canada. My study was a qualitative research to look at experiences, but the data in the United States and the United Kingdom have shown for quite some time that the reason why Black people are at higher risk for developing dementia um, and will be the group amongst, of course, other groups like Asians, South Asians, and Indigenous people who are impacted most by dementia is has much to do with the structural determinants of health throughout the life course. So when we look at a life course perspective and the experiences that these particular groups have around income and poverty and socioeconomic status and food insecurity, all of which are structural determinants of health, that are outcomes of inequities within our social structures, they fare worse when it comes to
Mhm.
dementia risk.
Mhm.
Um, so there are three main factors with respect to dementia risk and the fact that these communities are at higher risk. The first one is called modifiable risk factors, and those are things like smoking and exercise and lifestyle factors that can be modified or changed. The second one are what I just talked about, which are the structural determinants of health. And then the third one, which is perhaps plays less of a role, are biological issues. They're finding that higher levels of protein and amyloids. I'm not a biologist, but amyloids in the brain specifically of Black women are higher. So some of the studies are indicating that Black women have the highest risk for dementia, right? So that there's a biological component, which is not the biggest component, which doesn't play the biggest role, but it's there. But even the modifiable risk factors to me do have to do with race. You know, food insecurity, your lifestyle, your access to green space, your access to healthcare, your access to good nutritious food. Many of these things are connected to income, to poverty, to socioeconomic status. And Black people and other racialized people are disproportionately low income and poor. So for me, everything always relates back to race, right? But it also, of course, intersects with issues of class and poverty and of income. So I've never, doubted that. But it's like a domino effect, but it always comes back to race. So you always have to ask, well, if we're talking about low income, who is disproportionately poor and low income in Canada? And it's Black people, just like in the United States, and it's racialized people. So just by that, when we think of the causal factors for high risk for dementia in these communities, once again, it's the very same communities that have higher risk for stress, for high blood pressure, for respiratory disease, for diabetes. And as health professionals, we now know that genetics and biology do not play the biggest factor in respiratory illness, diabetes, and cardiovascular disease. We did believe that perhaps 10 years ago, that genetics and biology played the biggest factor. We know now that it does not. What plays the biggest factor are social, environmental, economic factors. Those are the structural determinants of health, right? So it's the external factors throughout the life course, not the external factors that played a role last year, but throughout the life course from childhood to adulthood play the biggest factor in health outcomes. And the negative side of that, the negative side of those structural determinants of health, such as low education, unemployment and underemployment, not being able to access healthy foods, inequalities within labor, inequalities within employment. All of those factors, the downside of those structural determinants of health are disproportionately felt by Black and racialized communities. So healthcare professionals who should be teaching this stuff can't deny this. This is in the literature.
That's right.
This is evidence-based now, but still to this day, they neglect this information. So they are educating young people who are going out to become clinicians in various spaces without their knowledge. So then I really don't expect clinicians to engage with these issues because they're not being taught these issues. So in my book, that's what I point to, particularly at the end of my book, where I talk about how do we decolonize various mental health spaces. The first issue I take up are universities and research and funding streams and the gaps in faculties of medicine and health professions like nursing and social work. That's the root of it. Because if they can start to engage with race and racism as a legitimate health issue, then they're going to teach it. And then students will come out of university with that knowledge and be fully prepared and equipped to engage in a conversation with clients or patients around those issues in clinical care.
Yeah, it's clear reading the second half of the book that you are really passionate about this. The contribution the book makes to the field of health education, I think is quite significant. And like your argument, I think specifically about the limits of cultural competency is bang on. So like you say that really, teaching a kind of multicultural competency has little to no relationship with justice. It doesn't have any real consideration for that. And if the goal is to achieve what you call health equity, we need stronger medicine than just like cultural competency. I think, if I'm reading you correctly. And so, I guess I wanted to ask you to give a bit of a definition of that idea of cultural competency, how and why you think it's accepted as a principle of health education, and why you're arguing for a much broader structural competency in health.
Yeah, I mean, that's a great question. I love this topic. I got excited when I read about, for the very first time, structural competency, probably back in 2015, by probably my favorite health author, Jonathan Metzl. He's not Black, he's white. He's a white psychiatrist, but also, which is what I love about him, he also has a PhD in a social science. It's either sociology or women's studies. So that mix of being a psychiatrist, a medical doctor, with having a PhD in a social sciences is what, for me, makes him so great. And I read an article that he wrote about structural competency, and I was like, what's this? Because as a health person, we all talked about structural competency. So I said to myself, I was still in Nova Scotia, and I said, I'm going to start talking about structural competency more. I want to bring it to the people at Nova Scotia Health because they often ask me to deliver presentations. I want to introduce this concept to them. I have colleagues, some of them are Black, at Dalhousie who are doing work similar to mine. They're looking at Black people and health. And I want to kind of introduce this term to them. And I kind of did. And now many of them are talking about the structural determinants of health and structural competency. And what I did was, in the beginning, I distinguished between cultural competency and structural competency. And I say that we should not abandon cultural competency. Cultural competency is about meeting your patient halfway. It's about understanding this patient of yours who is from another country. It's about being patient with them. It's about being sensitive. It's about having empathy. It's about understanding their cultural orientation, the fact that maybe religion is part of the ways in which they understand health. It's about all of that. I mean, sensitivity, empathy, patience are great things. I'm not suggesting in my book that it needs to be abandoned. But what I do say in the book is that you can provide all the sympathy and empathy and patience to a patient, but if that patient is struggling with food insecurity and employment insecurity and all of the struggles that many people, housing issues and home, all the struggles that people face externally in their lives, the empathy and sensitivity that you give to them isn't going to solve their problem. They're going to keep coming back to you because they've continued to have to deal with unemployment and food insecurity. They will continue to come to you as a doctor because those issues, those real life issues they're struggling with, their housing issues and their employment issues, are having a real impact on not just their mental health, but also their physical health.
Right.
So I say to the readers, yes, we need to be empathic. Yes, we need to be sensitive, but that's halfway. That's half of the issue. What we also need to be is structurally competent. And I distinguish between cultural competency and structural competency because I say that structural competency is more about addressing the structural inequities that are impacting on that patient's well-being.
Yeah.
Dealing with those external upstream factors that are weighing on that patient who keeps coming back to you over and over again because they haven't solved those everyday life issues. So what I'm saying in the book is that it's not enough for that doctor or that nurse or that social worker to address clinical problems simply within the healthcare system, simply within the hospital, by forging partnerships with the dietitian and the social worker in the hospital, et cetera. That's all great. They do a great job of doing that, doctors. They have those big teams that they work with, right, to deal with patients in a holistic way. But I say that they also need to form those partnerships external to the hospital. Are you forming partnerships with the legal clinic? Are you forming partnerships with the food bank? Are you forming partnerships with the employment center, right? Because if your patient is dealing with real world issues having to do with legal issues and food insecurity and housing insecurity, then it is your job, it is your responsibility as a clinician to forge partnerships. And I'm not saying that you're doing these folks' jobs, but to
Mhm.
form partnerships with individuals in those sectors to identify ways to address the real world problems that your patients are facing that keep them coming back to you.
This question is along the same lines of talking about structural competency, and I just wanted to say like one of the things I find valuable about that idea, and I love Metzel's work too, is that it lets us bridge things like health and seemingly unrelated spheres that are actually deeply related, like climate action and talking about infrastructure. You talk about how one of the determinants of health is actually decaying infrastructure. And we're starting to see how important that is now in terms of how severely climate-related events like floods, wildfires impact certain communities differently because of their infrastructure. But those are only the like large visible disasters. What from the Enlightenment to Black Lives Matter is getting at is that there is an everyday disaster happening in terms of health disparities linked to income, housing, food, as you say, but that, mental health professionals who you're talking a lot about in the book are just not exposed to that everyday reality. Do you think that's like, where do you think that kind of that blindness comes from? Like, is it an actual refusal to engage because it would lead to more advocacy? It would lead to the need for these kind of partnerships with more grassroots organizations, more, fence line communities. I mean, why would it be that these major health institutions wouldn't want to overhaul the structures that make people sick?
I don't feel it's a refusal. I think it's lack of training. I go back to that. This isn't taught in medical schools. It's not taught in the health professions. Um, it seems as something, I guess, for some health professionals, very exotic and out of place and
Mm-hmm.
not clinical enough, right? There's a
Right.
focus. Certainly, I spent some time in nursing. I was teaching in nursing at Dalhousie. There's a hyper focus on the technical skills, how to put a needle in, and all of those things that are extremely important. I'm not saying they're not important, but when I first came to the School of Nursing, back in 2012, I received so much pushback because I was teaching a course called the Social Determinants of Health, and the students questioned why I was teaching it. And they went to my director actually and launched a complaint against me. Um, they all contributed to that complaint. I think it was a letter or an email. And she received it and she was upset. And she says, Ingrid, exactly what you're teaching is exactly what they need to know. She also said that I want nursing to be seen as an academic discipline. Right now, it's not. And they need to understand that the social determinants of health have everything to do with being a nurse. But I received so much pushback because this is not how we understand nursing. This is not how we understand the health professions. And this is not how typically most nurses are trained. So it seemed off course.
Mm-hmm.
I understand that now. But the pushback was vicious, right? To the extent that you're going to file a complaint, all the students in that course, that there were a lot of them. That was a
Mm-hmm.
huge course, and send it to the director because they were angry. Um, there was a question by one student, Dr. Waldron, why are you teaching us sociology?
Mm-hmm.
Right? So that kind of sums it up. So this is, to me, about how training is done in the health professions.
Right.
And if anything different comes into play, people want to know, what is this about?
Mm-hmm.
Right? So it's not really the fault of the students, right? That is what they know. That's how they've been trained. That's the information that they're being fed by the
Yep.
professors who themselves were trained that way. Right. So I
Yeah.
can't, at that time I was upset, but I can't really be upset with the students because there's a root. It's rooted in uh, these professions, these health professions, and how they go about training and what they tend to ignore. I don't feel it's a refusal. There might be the odd person who who refuses to teach this information, or they don't think it's legitimate enough. They don't think it has a legitimate impact on people's health.
Mm.
There's enough research over the years around the world, but also in Canada, to indicate that this is evidence-based information and it's real. Forget about racism, but just let's think about all the other structural determinants of health. The idea that unemployment and underemployment can lead to health issues shouldn't be so strange anymore.
Agreed. Yeah.
So similarly, racism and the experience of racism, and the fact that racism in many journal articles has been conceptualized as a major stressor. And we now know, as I said, we now know that biology and genetics play less of a role in disease than we used to, and that everything is really rooted in stress. And the chronic diseases that we are dealing with at high rates nowadays, such as cancer, are a result of stress and of certainly what we eat. So environmental toxins and all the stuff we're eating. We know that now. We didn't know that perhaps 15 years ago. We were still focused on biology and genetics. However, I will say that I still believe that faculties of medicine are focused on biology and genetics, despite the studies that have come out. There's this stuck in our way kind of attitude, particularly in medicine, where they just don't want to let go of that genetic biological framing. And I'm not sure why. Is it that they don't feel that they're prepared to or want to deal with the external stuff, as you say, because that means that they're going to have to be involved in changing systems. And that's not what they signed up for.
Right.
I remember way back, when I was at Dalhousie, I think the medical faculty, actually, they found out I was teaching the social determinants of health course, and they wanted me to start teaching it in medicine. I don't know if that would have worked because I was employed in nursing, but they spoke to the director, the same one who I love, who gets it, and they spoke to her and they asked her whether or not Ingrid could start teaching the social determinants of health course. And I heard from one of the students I was supervising who was in medicine, and she said to me that whenever the social determinants of health was discussed or mentioned in one of her medical classes, there seemed to be pushed back by the other students. She wanted it, and some of her friend group, they wanted a course on the social determinants of health, but whenever it was mentioned, the other students acted like that's not legitimate. They didn't want it. So it never happened. I never ended up teaching social determinants of health in medicine. I don't know why. I'm not saying it's the students, but there was a large cohort of the student body in that class who kind of roll their eyes.
Wow.
Right. So I think it's perception and imaging that this is not real. This is not medicine. This is not scientific. This is not evidence-based, which is, of course, incorrect.
Yeah, and I mean, there's so much that could be learned by allowing oneself to be open to those social and structural determinants of health. But I think for a lot of folks, whether they're conservative or liberal, there's a certain hostility to politicizing a discipline that's not supposed to be political. That's, medicine, it's supposed to be
Yes.
Exist outside of politics. I'm not necessarily supposed to have a deep understanding of social forces and intersectionality because I'm here to learn how to fix people,
Right.
I'll have the minimum level of cultural competency if it'll improve my bedside manner and make me better at my job. But it's not, it can't go down as deep as my values because that's political. That's something outside of, the sphere of medicine. But
You know what, Scott?
yeah,
It's also Cartesian.
right. Yeah,
So
yeah,
right? So this idea in medicine is that the body is mechanical. The body is something to be fixed. This refusal to understand how external factors impact on the body. So the job of the clinician is to fix what's wrong with the body. And when the body breaks down, it's like mechanics.
Mm-hmm.
When the body breaks down, it's breaking down because of something internal.
Sure.
And as a doctor, I need to fix that and put the pieces back together. So the idea that racism, forget about racism, but racism and food insecurity and employment insecurity could come into play is not something that's even entertained.
Mm-hmm.
Because in that Cartesian approach, it's about fixing the body and the
Right.
internal issues that have caused the breaking down of the body.
Mm-hmm. And that seems to even be true in psychiatry from your
Yes,
analysis, which is kind of
yes.
bizarre that that Cartesian binary, which, enforces this division between the mind and the body, that would even come into play in psychiatry because you're treating the mind. You're treating
Yes.
something that ought to be looked at as irreducible in its plasticity and its mutability and all of these things, and instead you're kind of applying a more biomedical, like, constrictive framework to it. You seem to actually say in the book that basically all psychiatric treatment tends to rely to an extent on stereotypes, but that there's a rampant racialization within psychiatric diagnosis when you really look at it. And like, I guess, I wanted to ask about this. Do you feel like the stereotypes that exist in the discipline of psychiatry persist partly because the history of those stereotypes is not understood?
The stereotypes don't come from psychiatry. The stereotypes come from society.
Hmm.
And those stereotypes that inform psychiatry. Psychiatrists are just human beings,
Right.
right? So they're exposed to and vulnerable to taking on all of the stereotypes that we have in society about Black people.
Hmm.
They're not immune to it because ultimately they're just people. So many of the stereotypes, negative stereotypes and perceptions that we hold about Black people then find their way into psychiatry. And once again, I should also point out when you talked about, it's kind of surprising that psychiatry is operating similar to medicine. It's that, psychiatry is a branch of medicine. Psychiatrists are doctors, they're medical doctors. So
Mm.
they're trained in the same way, right? So we have to think about that. And
Sure.
medicine is powerful. I talk about that in the book. I talk about psychiatric imperialism. And the reason why we see
Mm-hmm.
psychiatric imperialism is because medicine, forget about psychiatry, but medicine is a dominating force, Western medicine, around the world. Even
Yeah.
in African societies and African countries, I did a study speaking with African psychiatrists and mental health professionals, and they adhere to proudly your Western medicine and your Western modalities because they said to me, it's evidence-based.
Mm.
Perhaps, but there's different ways to look at how we understand evidence-based. Um, so it's a dominant force, and psychiatry is as well. Um, but psychiatry isn't immune to understandings about Black people and Black life, right? So, and perhaps psychiatrists would take issue with me saying that diagnoses and labeling are faulty, all of them. Maybe not all of them. I think obviously labeling helps people. The labels that we see in the DSM, which is the psychiatric Bible, that handbook, which helps them to assess and diagnose people, is helpful. It's good to have that. It's helpful. And it's only recently, I would say, that they've had a stronger kind of cultural analysis. They still have yet to engage with issues of race. But they put out the DSM every few years and they try to improve it. So that's a great thing. And I understand that it's helpful. It's a good guide, but I'm stubborn in saying that labeling, I have problems with labeling. Labeling leads to diagnosing, and diagnoses follow you for the rest of your life, and can harm you, for example, in employment. And I talk, as you know, a lot about the overdiagnosis of misdiagnosis of Black men with
Hmm.
schizophrenia.
Right.
The
This is
most
such an important point. Yeah.
Oh, and Metzel talks about this. I love his work on this. Schizophrenia is one of the most pathological illnesses you can apply to anyone, and that follows you for the rest of your life. And
Mm.
Black men are overdiagnosed with this, and I provide arguments as to why. And that's to me a really great example of how labeling is informed by negative stereotypes, how that then leads to diagnosing and assessment, and that how that can harm people throughout their life course. So, in the book, I point to scholar and psychiatrist Dr. Suman Fernando, a British
Hmm.
Sri Lankan hero of mine, just like Metzel. I love his work. Unfortunately, he died earlier this year, but
Hmm.
he was the foremost scholar at looking at the racialization of psychiatric diagnosis, particularly schizophrenia. He put out a lot of articles about that, and he says that the perceptions that we hold of Black men, particularly as violent, aggressive, criminal, and pathological, often leads mental health professionals to apply the most violent, aggressive, hostile diagnosis to them, which is schizophrenia. But I should be very cautious that that's not necessarily true of schizophrenia. Those are the perceptions
Hmm.
that we have held and that popular culture has played a role in. Those are the perceptions we hold of people with schizophrenia. I used to fear them as well. And then somebody said to me, actually, Ingrid, people with schizophrenia are not necessarily violent, but that's how it's portrayed in the media. And I
Right.
think back to a movie I watched when I was a kid called One Flew Over the Cuckoo's Nest with Jack Nicholson. And I think he had schizophrenia in that movie. And that was my first kind of encounter with schizophrenia. And he was portrayed as crazy, out of line, off the handle, violent, hostile. And that
Hmm.
was my first impression of schizophrenia. And in popular culture, that is how it's constructed. So you apply the most pathological, what is perceived as or constructed as the most pathological mental illness to Black men who are also seen as pathological, independent of that
Hmm.
diagnosis. It makes sense. So the colliding of that negative stereotype of Black masculinity with the very negative perceptions of schizophrenia then leads to the overdiagnosis or misdiagnosis of schizophrenia in Black men is how I see this playing out and how
Yeah.
I see most labeling. If you have perceptions, so another example is, Black people are seen in popular culture, but in general as strong. And we say that as well about ourselves, which in itself is problematic, but we probably don't have time to go into that. It's great to be strong, I suppose, but it has negative impacts when people think Black people are strong, so we can take it. And that means that we don't deserve care or empathy or sensitivity because we are so strong, because we are the mules of the world. But Black women particularly have taken on this stereotype and they say, I'm a strong Black woman. And they say it as a rallying cry, as something to be proud of. Perhaps, but I would say that this belief that you're so strong often means that you're too strong to seek out care because everybody thinks you're so strong, because you think you're so strong. Then that means that you think that going to see a psychiatrist is weak. And many Black people will say that. They will say seeking out therapy is for white people. We're strong, Black people, we're strong. We don't need to do that. That's white people's thing, right?
Hmm.
So we can see how problematic that is because Black people underutilize mental health services. Consequently, they're not getting the care that they need because they think they're so strong.
Right.
So this plays out in diagnoses whereby the studies have also indicated, particularly in the United States, that Black women are underdiagnosed with depression. So when you claim, as Black women do, that you're strong, and the rest of the world thinks Black women is strong, and that's very clear in popular culture and music. Black women are often portrayed as strong, independent women. Then it's very difficult for a psychiatrist to see Black women as vulnerable or depressed. You see what I'm
Right.
saying?
Yeah, absolutely. No, I take your point completely that like and it has a particular character and specific effects within Black communities, but I think generally, championing resilience
Yes.
as like a good as self-evidently good puts people in a position where they don't really feel like they can ask for help, because
Right.
that
Yes.
idea of resilience, it tends to be pretty shallow. It's like,
Yes.
a disaster takes place and then you say Nova Scotia strong, and nobody knows what that
Yes.
means, except you're just supposed to like galvanize yourself to the next crisis, and like
Yes.
that's not care.
Yes.
Um, but yeah, like I say, like you're really focusing in particular on the kind of the capacity to see the black body in
Yes.
a non-stereotypical way, to not reduce blackness, as you say, to a monolith,
Yes.
and one of the ways you get into a discussion of the consequences of these controlling images is by talking about the ways that internalized racial stereotypes tend
Yes.
to prevent, as
Yes.
you say, a lot of black people from seeking help. In your
Yes.
words, this is from the book, you say culturally determined beliefs about mental illness will also influence how people present or express symptoms of mental illness. So it's has everything to do with seeking help and the kind of help you get.
Yes.
And so, where in your experience does the hesitance come from? Is it just the internalizing of that sort of value of strength? And what are some ways that your research suggests it can be remedied? Like what are the kinds of support that you've found Black communities respond best to, maybe Black women in particular respond best to when it comes to trying to reshape the kinds of care that are available to actually like resonate with the groups that need that care?
Well, I would say the factors that contribute to Black people underutilizing mental health services or not utilizing them at all are rooted in probably two or three issues. The first one would be culture that comes directly from Africa. So, as Caribbean people, African Nova Scotians, Black Americans, Black people around the world, we all descend from Africa. In African culture and in African descendant communities, there is a belief that if you have a mental illness, you're being punished. It's very strong, and it's not, some people will say, well, that's probably a belief that's held by the uneducated, but it's not. It's held by the uneducated, the educated, many people. And I don't want to stereotype African peoples of the diaspora because, many of us have various belief systems. But every time I mention this to Black people from different cultures, they nod, like they understand what I'm saying. And if you continue to have that mental illness, you're not praying hard enough. This is a huge belief
Hmm.
in Black communities. Pray more, pray more. Go to the church. You're not trying hard enough. You're not praying hard enough. Just pray it away. And every time I say that to Black people, they laugh because there's a knowingness, right?
Hmm.
So this spiritual, religious kind of ideologies that many Black people have, as you know, Black people can be hyper religious. Church going is big in Black communities. It certainly was in Nova Scotia. When I was there, I was a bit of an outlier.
Hmm.
When people found out I didn't go to church, they looked at me like I had three heads when I was in Nova Scotia.
Hmm.
I'm talking about Black people specifically, right?
Hmm.
But Black people in the United States and the Caribbean, hyper religious. So this kind of belief around spirituality and evil spirits and religion and prayer is really huge. So that's
Hmm.
one factor, is that some people believe that you are being punished and perhaps you deserve it. The second one is what you said. It's this issue of weakness. This idea that that's for white people. We don't do that. Black people, we don't do that. We are strong people. We've been through so much. If you go to seek a therapist, you're wasting your time. Be strong, right? And this is a particular burden sometimes for Black women who are often seen as the pillars of Black community of
Right.
the Black community, right? By many people. And there are a lot of kind of single household Black women kind of raising children on their own. So this idea that Black women are the pillars of Black communities is real. And there's an expectation for Black women to be strong, particularly when Black women tend to maybe complain or share their struggles. It's often dismissed
Hmm.
by Black men, by Black family members, extended family, etc. They're not taken seriously. Those are the two major factors. It's about religion and prayer and dealing with it that way. And if you're struggling with mental illness, then you're being punished and you're, for whatever reason. So there's a taboo and stigma
Hmm.
around you. And the other thing would be, as I just said, it's not traditionally, it's not normative in many Black communities, but it is becoming so. So I talk about that in my book, that over the past few years, Black people have engaged with all of the different modalities that other communities are engaging with. It's definitely, I mean,
Right.
Black people are engaging in yoga and mindfulness healing and meditation and all of these, what we call alternative modalities that they didn't always used to engage in. And of course, what I'm seeing is Black people are seeing psychiatrists more and more and therapists. And some of my friends who are seeing therapists, they say it kind of proudly, where in the past they would have hidden that for me. Like I'm shocked by
Right.
some of my girlfriends that they're not hiding it. They're not embarrassed. They say very proudly, "Oh yes, my therapist said."
Yeah, like there is a shift happening, and you want to kind of push it, you want to, I think, leverage that to a certain extent and get it moving in the direction that you think is ideal, which is, more local health services. So, ensuring that you can actually get to these places to receive care, that like they're in community. You talk about that. You talk about how not excluding spirituality from the conversation is
Yes,
actually pretty crucial. You provide a lot of different solutions at the end of the book, and I think like my sense is that you're just trying to keep this opening open. This particular pivotal moment we're in, where, as you say, like the Canadian Public Health Association has acknowledged that anti-Black racism is entrenched in virtually all Canadian institutions, though probably especially in the economy, in rates of incarceration, and so on. But like I think the whole opening thing, it comes from the fact that you're seeing that this progressive perspective that's emerging, this shift that's happening, didn't come out of nowhere. That
that's
it's the
right.
result of social movements fighting for a shift in the way that race and racism are engaged with. So, like you
Yes,
talk about the U.S. Civil Rights Movement, and the fact that after the U.S. Civil Rights Movement, to quote the book, psychiatrists began to question the validity of applying Western psychiatric principles to other countries. You talk about how the Black Lives Matter movement kicked off a larger conversation
yes,
about the impacts of racism on poverty, jobs, housing, the mental health of victims and their families.
yes.
These are things that, as you point out, public health has historically said very little
That's right.
about.
That's
And
right.
so there is this moment where your work becomes especially prescient, where like because you're bridging theories of radical social change and health, it feels differently possible to transform institutions through that kind of collective action. So I mean, like we're in 2025 in the United States. We're in the context of a second Trump term, and you talk about Trump's anti-Black racism a little bit in the book. So and in Canada, you had a anti-woke federal, prime minister candidate in Pierre Poilievre lose
Yes.
in large part because of the association of that guy with
Yes.
Trumpism. What do you think is going on when the zeitgeist becomes more anti-racist, more anti-colonial, and then, you see these kinds of changes within psychiatry, for example, like that. I'm looking for basically your sense of how that translation or that spillover happens from the streets to the spaces of the clinic, from, politics through direct democracy to institutional change, and like how you sort of feel like we can maybe just try and keep that pride open, that space of translation, of spillover.
I think you're being kind to psychiatrists because despite everything you're saying in terms of, you know, discourses and actions around decolonization and anti-racism and EDI, I know that that's being dismantled in the
Mm,
United States, and I hope that doesn't happen in Canada, but I see some signs of that.
mm,
Despite all of that action, despite what happened in 2020 with COVID and the realization that it was disproportionately impacting Black communities, which was actually a good kind of good evidence about health disparities based on what we talked about earlier, that
mhm, mhm.
social inequities are linked to health disparities. Despite what happened with George Floyd, despite all of that excitement that happened and promises made by universities, including my universities and other organizations, that we are going to do better. We're going to do better on EDI. There's been very little progress to me in psychiatry and mental health, other mental health professions. The movement that I see are really around people like myself who are teaching or activists around health equity.
Mm-hmm.
I see it, I feel like it's the same players. And I'm
Right.
not seeing enough of a movement within our health spaces that tell me that we've progressed around anti-racism and the importance of looking at race and racism as legitimate factors in our health. I haven't seen that movement.
Right.
I haven't seen it in psychiatry. So
Mm.
yeah, that concerns me. I mean, I'm not going to say it's not happening at all, because as I say to people, there's progress. You know, when at the end of my book, and I talk about decolonizing our spaces, and I talk specifically about the need for research institutes that focus on anti-Black racism and health or structural determinants of health. It's
Mm-hmm.
happening slowly. I know Black professors who are now leading kind of anti-racist health centers or institutes at their universities.
Mm-hmm.
I see a new Black institute at Dalhousie.
Mm.
I'm seeing these institutes and centers within universities focusing on anti-Black racism or anti-Black racism in health popping up slowly. So it's led by Black folks.
Mm-hmm.
I'm seeing job ads at different organizations, including hospitals in Canada, in Toronto recently, that have focused on anti-racism chair positions, looking for people who can chair
Mm-hmm.
centers and co-direct centers. It's happening. So it's happening slowly. Where I don't feel it's happening is within that clinical environment,
Mm-hmm.
that sit-down environment between the psychiatrist or the therapist and that patient sitting in front of them. I still don't think that they have the language or the knowledge to engage comfortably and properly in discussions, because it's going to take some time. Because as I said, it's rooted in the courses that are being offered at universities. And not only the courses, but the people that you hire. And, you know, a little before and during the George Floyd era,
Mm-hmm.
there were cohort hirings at various universities in Canada. That's progress. We saw that at McMaster. We saw that at McGill, shockingly. We saw that at York University, and more recently at Dalhousie. That's progress. That's great. But some people have said to me, there's now been a clampdown. No more cohort hiring of Black professors in different fields, right? But that cohort hiring was an opportunity to continue to progress in many ways.
Mm-hmm.
And that just kind of exploded during the George Floyd era. So, you know, that concerns me, that there's all these stops and starts.
Yeah.
You know, 5 steps forward, 10 steps back. And that's what I see happening in Canada in very subtle ways. So in Canada, the government hasn't said, like Trump has said, we're dismantling everything EDI, we're taking it away. You know, we haven't got to that place in Canada, but I see very subtle examples of lack of progress, which to me amounts to the same thing.
Yeah. No, in the States, they're seeing like a violent, sudden,
Yes.
rollback of rights.
Yes.
In
Yes.
Canada, I think you're seeing a kind of diluting of that radicalism that
Yes.
emerged in that moment, and
Mhm.
it's harder to perceive. And so
Yes.
often that's true of Canadian politics, I think. A lot
That's
happens
right.
in really
That's right.
subtle ways.
Yes.
But no, I really appreciate your book and you making the time to talk about it and giving us this very kind of practical understanding of the spheres of power and how progress has been made, but it's still kind of at the margins of that to a certain extent. But that, yeah, we should still mark the progress. These institutes, these centers are producing incredible work that, if we pay attention, can re-radicalize certain spaces, can potentially radicalize the clinic and make us a little bit more comfortable with, the vulnerability that is required, I think, of, you know, any anti-racist advocate of climate equity, health equity, and so on.
I just loved what you said when you said radicalize the clinic. I can see a paper on that. That's a beautiful paper, journal paper title, Radicalizing the Clinic.
Well, let's write it. Sounds good.
Because that's exactly what I am actually saying in this book. I just didn't say that, but I'm trying to get people to understand that we need to radicalize the clinic. Yeah.
Yeah, and I mean, it comes through, and some of the best work I've read on, you know, within critical health studies, that's what it's trying to articulate, you know, and it's not an easy position to take. I always, you know, personally respond well to that sort of rhetoric that says we do need an overhaul. We can't keep slapping Band-Aid solutions on these structural problems.
Yes.
Yeah, I really appreciate your always very thoughtful writing and reflection.
Well, once again, you've pulled out a brilliant interview that challenged me and made me think. So I thank you once again.